Welcome everyone to today's webinar. I am Mary Rectoris with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any and all questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to all of your questions. Also, in about a week following this webinar, we will be sending you the recording to the email you used to register. I am now going to introduce today's speakers. Dr. Paul Slozer is an orthopedic spine surgeon who is certified by the American Board of Orthopedic Surgery and the American Board of Spine Surgery. He has been in practice since 1994 and has been with Spine Care Medical Group in San Francisco since 1997. He is currently serving as president of the group. Dr. Slozer is also the medical director of the Spine Care Institute of San Francisco, co-director of the San Francisco Spine Institute, and director of surgical research. Dr. Slozer has authored more than 20 original articles in peer-reviewed journals, 6 book chapters, and has given numerous podium presentations at national and international meetings. He is also an editorial board member for several medical journals, including Spine, the Spinal Research Foundation Journal, as well as serving as an oral board examiner for both the American Board of Orthopedic Surgery and American Board of Spine Surgery. Dr. Slozer served as the Chief Medical Officer for Titan Spine since 2008. Dr. Barbara Boyan is a professor in the LST and William H. Goodwin Chair in Biomedical Engineering and Dean of the School of Engineering at the Virginia Commonwealth University in Richmond. She was a Georgia Research Alliance Eminent Scholar and Associate Dean for Research and Innovation in the College of Engineering of the Georgia Institute of Technology. Dr. Boyan is also a past chair of the Orthopedic Device Panel of the FDA and a past president of the American Association of Dental Research. She is a fellow in the American Association for the Advancement of Science, the World Congress of Biomaterials International College of Fellows, and in the American Institute of Mechanical and Biomechanical Engineering. In 2012, she was elected to the National Academy of Engineering. She was appointed to the National Materials Advisory Board of the National Academy of Science and chaired the Roundtable of Biomedical Engineering Materials and Applications from 2008 to 2011. Dr. Boyan holds 21 patents and is the author of more than 460 peer-reviewed papers, reviews, and book chapters. She has been a scientific advisor to Titan Spine since 2008. And Dr. Boyan, I'm going to go ahead and turn the floor over to you right now.
Thank you, and thank you all for joining us on the webinar. I would like to disclose, in addition to being a consultant for Titan Spine, I'm also a consultant for Institute Straumann in Basel, Switzerland, which is one of the leading dental implant companies in the world. And the work that I'm going to present to you is work that's been ongoing in my laboratory for over 25 years. So I am going to have you look at data, but I am going to talk you through it. I just want you to see that there are data, and these are all from published papers that support what I hope that you will enjoy hearing about, and that at the end of this you'll understand why I'm interested in doing the things that I'm interested in doing. So I am trying to advance my screen without great success, and hopefully I will get some help. We're going to try a new plan, and
Just one second.
Now we're going. Okay. So what I want to give you an overview of what actually happens when you put an implant into bone. And as I think all of you realize, that the implant itself, because of the way that it's placed in a bone environment, whether it's an orthopedic implant or a dental implant, that it actually, there is a space between the implant and the original bone bed. And that's an important concept to get, because in that space things have to happen in an organized way to achieve really good bone implant interface. The first thing that occurs that there is a fibrin clot that forms, and in that clot, on the fibrin fibers, the cells migrate into the site that are going to affect the outcome. So from the beginning, the material itself sets up what takes place in that fibrin clot. There cells that migrate in there originally, of course, are the cells that form the clot itself, as well as early stage immune cells that send out signals to other cells to migrate in. And amongst those cells that migrate in which is in the second panel, is the mesenchymal stem cells, or progenitor cells of some kind. These are not pluripotent stem cells. They're cells in various stages of differentiation, but they retain multipotency. They're able to differentiate into many different things, including bone cells, fibroblasts that will form scars. So the goal is to get as many cells as possible to differentiate into osteoblasts as they arrive at the site. Eventually, if we're successful in the goal, on the middle panel, you will see that these cells form woven bone, primary bone, and they fill up the space between the implant and the original bone bed. And ultimately, in the fourth panel, the second one from the right, this material is replaced through osteoclast resorption, and ultimately, in the last panel, the goal is to get good Haversian quality bone that is now going to be permanent against the implant as close as possible. So to achieve the least amount of space between the bone and the implant, we need to have an implant that facilitates the process. And I'm going to show you what we've learned over these 25 years to make that happen. First, we want to get the right cells to come into the environment. We want them to get the right signals from the environment. We want them to become osteoblasts, form bone, and ultimately, when that bone gets remodeled, that it gets remodeled at the right time, because we need to get net new bone formation. And so let's take a look at the next slide. So the question is, why doesn't this happen with materials like PEEK? Why does it happen well when we use a titanium or titanium alloy, but it does not happen well when we use something like PEEK? And to get that, to understand that, we need to take a little bit of time to understand what the mechanisms are that cause this to happen. Now, if you think about originally in bone, in native bone, it's constantly being remodeled. So your entire skeleton is constantly being turned over, and once a year you have an all new skeleton. And part of what causes that to take place is the mechanics of bone remodeling. That there are small microfractures that occur that activate the osteoclasts to come into the site to remove bone. They create an environment that is conducive to cells that are going to become osteoblasts to migrate onto that site, to set up shop, become osteoblasts, form new bone, and ultimately, sometime in the future, that is going to be remodeled again by osteoclasts coming into the site. So we know that when osteoclasts resorb bone, that they're creating a microenvironment that is attractive to cells that we hope will become osteoblasts. And that has shape. It also has chemistry. But we've only recently begun to understand the importance of the shape, and that's the next thing that I want to show you. So in this particular picture, this is not one from my group. This was published in 2004. This is what it looks like when an osteoclast resorbs bone. It leaves behind physical structures that have shape and texture that cells that migrate onto those osteoclast resorption pits can feel. Now here's an osteoclast in the top panel, and you can see how large a cell that actually is. So it covers a reasonable amount of territory. But an osteoblast is a smaller size cell, and it has to do some things when it gets onto that site. It needs to sense the structure, it needs to sense the chemistry, and so it needs to sense something that's smaller than it is. And an osteoblast is about 10 microns in diameter, and when it gets onto the right shape, it changes shape. It goes from being a flattened cell, one that has potential actually to differentiate into a fibroblast and form scar-like tissue. It changes into a columnar cell, and it now has the ability to synthesize the osteoid, the unmineralized matrix, and then mineralize that matrix and form bone. So just to go back over this one more time, you put the implant into a site. The first thing that happens is that fluids in that site absorb onto the surface of the bone. If the implant has the right properties, those fluids that will absorb will recruit mesenchymal stem cells through the fibrin clot onto the surface. Those cells will attach, they will increase in numbers, they will become osteoblasts, they will form osteoblast matrix, and that matrix will become mineralized, and ultimately it will be remodeled by osteoclasts. So we need a surface that tells all of this to happen right from the outset. And then let's take a look at what kinds of surfaces do that. So in bone, there is structural complexity. There is a macroscale complexity that happens when the osteoclast is forming its pit. There is a microscale texture that has to be smaller than the size of an osteoblast for the osteoblast to actually know that it's there. And then there is nanoscale, and this is at the biochemical level, the way that we used to think about it biochemically, but it's also structurally. There is information in the structure that the cell can sense that makes the cell do certain things. And it interacts with the proteins that have adsorbed to the surface through a kind of a protein complex called an integrin. And as the cell changes its shape to become ready to be an osteoblast, it makes different integrins. It makes very specific integrins that unless it makes those integrins, unless it makes that shape change, then it doesn't become an osteoblast. So I want to show you that it really does look like this. This happens to be the nanoLOCK surface, the one that I'm going to describe to you how we got to the nanoLOCK surface. And you can see the texture. Now that yellow thing is a real live osteoblast. And that osteoblast, you can see it's 10 microns in diameter. So for it to know about the shape has to be smaller than it is. And actually on this surface, there is a macro texture that's a certain size. There's a micro texture, and the cells, they nestle down into the micro texture. And now there is a nano texture, and you can see how small it is in comparison to the size of the cell. Okay, so can cells really tell? Does any old thing work? I mean, if we just manage to get a macro texture of a certain property, a micro texture of a certain property, and a nano texture of a certain property, would the cell know? Would it know where it is? Can it really tell the difference? And so we started to ask questions. How smart are these cells? What do they know about? Is there a range that we can work with? Can cells tell really and truly? Is there a shape that they can feel? Is there something that will make certain things happen where another shape that might be similar but not identical won't make those things happen? And how do we know that any of this stuff is biologically relevant? So these are 6 different surfaces. These happen to be dental implant surfaces, and I have to say the dental implant world was ahead of the orthopedic world in studying these things. These are all surfaces that are on implants that your family dentist can put into your mouth today. And you can see that they're all a little bit different. And they all have different success in vivo. In meta-analysis of implants say that there really is a difference at the implant level of how quickly these implants are integrated into the mandible or the maxilla. And you can get an idea of they all share certain properties. They're all titanium. They all have a oxidized surface. They all are processed and cleaned in a similar way. They all have a similar shelf life, and they all have some version of a macro scale feature, a micro scale feature, and something submicron, which is less than a micron size. So to get an idea about whether cells could even tell the difference, we did some very controlled experiments. We used electron micromachining, which is the same processing method that they use to make microcomputer chips, and we gave them different shapes of a macro scale, 100 micrometer diameter, 10 micrometer diameter. We gave them different kinds of microscale and mesoscale features to respond to. And we learned that cells, even in this very crude experiment, could really tell the difference. They preferred 30 micrometer craters. They preferred the macro scale. They preferred there to be a microscale roughness that was a certain property. They like pits that are 1 to 3 micrometers in diameter. And they really preferred things that were etched and pointy rather than things that were anodized and not. So this is to give you an example of the kind of data this sort of experiment can create. But if you look down in panel D and panel F, you can see the difference in the nanoscale textures that we gave these cells to select from, and looking at how well differentiated they were as osteoblasts, we measured a protein that a very well differentiated osteoblast makes called osteocalcin. And if you look over to the far right, you can see that when they were given a 30 micrometer crater and the space between the craters, there was a ratio of 30 micrometers to 6 micrometers, and it was acid etched like in panel D versus the anodized version in panel F, that they were better osteoblasts when they were on the etched surface. So does this correlate to something clinically? Yes, it turns out that it does. When patients have implants that have this surface on it, this dental implant surface, they actually have bone forming 2 weeks faster than patients who have the anodized surface. So that is with clinical and human clinical trials. So there's something there about that shape, but we wanted to know more. So in collaboration with Titan Spine, and I must tell you, yes, I am a consultant for them, but one of the things that why I like consulting for them is that they have taken a scientific approach to identifying the best possible surface for their spine implants. And they did this in collaboration with my lab in a I want to tell you that this was done as science, not as product development at the time. So I asked them to make as many different versions of a surface as they could make within ranges of certain technologies. And they produced 26 different surfaces that we looked at. I had to decide which ones. Some of them looked good to me and some looked bad. And this was based on my experience thinking like a bone-forming cell. I made my brain go like an osteoblast. And I already knew I needed to have macro craters and micro pits and then different kinds of other textures that were interesting. And so we took 12 of them, and we did a very thorough analysis of the surface. And of those 12, we picked 3 that had similar roughnesses, but they had different morphologies. So I want to give you a little bit of a background. When we talk about roughness, there's lots of ways to look at roughness, and a person like me likes to characterize these things to death. So there's an average arithmetic roughness, which is the number most of you hear when you hear about roughness. And there's other measurements, and these are just some examples. There's the valley depth, there's the maximum height of the profile. There's maybe 20, 25 different ways we could measure this. And there's 2 that really stood out as interesting. One was skewness and one was kurtosis. And so we can give you these kinds of numbers with an R value or an S value, and I'm going to use R values because it's a little bit easier to describe. So just what do we mean when we're talking about skewness and kurtosis? Because these are numbers that are, we could talk about them for days, and in fact we did take real bone and we etched it and we looked at what was the surface of real bone. And real bone has a low skewness and a kurtosis around 3, which was unexpected. So when we started to see what these biomaterials might be producing, we were intrigued. The bottom line on skewness and kurtosis is that if the skewness is low and the kurtosis is around 3, it means that these are normally different distributed peaks that tend to have a pointy top, and then they're kind of even sides coming down, as you can see in this picture. So we took these surfaces. We had a classic surface, which we call the rough titanium, aluminum, vanadium alloy, and then we had surface number 5, number 9, and number 12. And these are some of the measurements that we made. If you look down at panel H and panel I, you can see that 5 and 9 had a kurtosis around 3, and they also had a very low skewness, where number 12 had a slightly higher kurtosis and a higher skewness, much higher skewness. So then we analyzed how cells responded, and these are mesenchymal stem cells that were cultured on these surfaces. And what you can see on number 9 is that alkaline phosphatase activity was higher, and that's an early differentiation marker of an osteoblast. Was osteocalcin higher? And the osteocalcin is a marker of a late level of a well-differentiated osteoblast. And you'll see in all these slides that we always have TCPS. That's tissue culture polystyrene. That's necessary for cell biologists because you can't see through titanium. So we want to make sure that the cells are healthy. We also noticed that they made their own bone morphogenic protein, these cells, and they made more of it on BMP2 on surface number 9. They also produced more angiogenic factors, and here you can see an example of vascular endothelial growth factor, which is necessary for blood vessel formation. And they put more of that on number 9. So what was so special about number 9? Now remember I told you you've got to have the right integrins to get this differentiation into osteoblasts. And not surprisingly, on number 9, they made more alpha-1 and more alpha-2 integrin, which are the very special integrins that need to be produced. And they made less alpha-5. And that is good because that says these cells are differentiating into osteoblasts on the number 9 surface to a greater extent than they are on the other surfaces. When we went back and looked, again, we saw that this kurtosis was lowest, it was closest to 3 on number 9, and the skewness was low on number 9, telling us something about the way these cells like to see things at the nanoscale. They want to see that particular, they like their nanotexture to have certain properties. And if you remember back to what the cell looked like that was sitting on the number 9 surface, that's what it looks like. Those peaks are very regularly shaped, they've got pointed surfaces, and they are even-sided projections. So how does this have anything to do with spine? And this I just put in there to remind all of us that we got to get back to real life. And remember what happens is that we're going to have a fibrin clot, and the mesenchymal cells have to migrate in and get the right information coming in and the right information on the surface. But also they need to send the right information out to other cells, because it does not take a rocket scientist to understand that a surface only has room for one layer, and yet you've got to get bone to fill in that space. So what we want is for the surface to tell the cells, you need to do certain things, and the cells tell cells around them that they need to respond in certain ways. So we set up an experiment to test that, and we put surfaces, we put actual frank osteoblasts onto various surfaces, and then we let them make factors that would tell the cells that were on plastic, on nothing, would tell those cells what they needed to do. And you can see from looking at that when we gave cells these microtextured surfaces, they actually told the cells that were sitting on plastic to make more VEGF, to make more factors, transforming growth factor beta, that are involved in either vascular growth or telling osteoclasts don't resorb too quickly, or telling these cells to become osteoblasts. And I just want to show you how complicated this is, and to assure you that we've really done our homework. Everything you see on this slide, our laboratory worked out. This is a signaling pathway that when a mesenchymal cell is sitting on a microtextured surface like nanoLOCK, that the cells produce the right kind of integrins, all of the signaling goes on, and in the end, in this particular case, they produce a factor called osteophotegrin, which actually stops cells from becoming osteoblasts too quickly. So this is very important, is the controlled activity of osteoclasts, and here is proof to you, showing you what happens when we put mesenchymal stem cells directly on the surface. They produce factors that when we put that medium onto osteoclasts, reduce the activity of osteoclasts. Now we want the osteoclasts to resorb, but we don't want them to resorb too soon, because we need to get the surface covered with bone. Okay, just to remind you, now we're talking about mesenchymal cells coming in, colonizing the surface, producing factors that tell the blood vessels to grow in. We've got to have a vascularized bone, tell the cells to make woven bone, and regulate the time frame at which the osteoclasts resorb and remodel that bone so that we get good quality bone on the surface. Now, does this happen in vivo? Absolutely. So in this case, we worked with a spine implant company in Israel, and we put this surface on pedicle screws, a very rough version of the surface, not so fancy as the nanoLOCK surface. And you can see right here that the quality of the bone against a smooth surfaced implant, although made out of titanium alloy, that when we torque these things to failure, interface between the bone and the smooth surface implant was not adequate, and so that's where the failure occurred. But when we put bone onto a microtextured implant alloy and we torqued to failure, then the rough surface, the bone actually adhered to the surface. This is like an onlay. This is not growing into, this is right on the surface of the pedicle screw. So yes, it actually plays out in real spine, and in fact the pull-out forces on the rough surface were twice those on the smooth surface. So why, again, why do we not see this on PEEK? PEEK has got a different chemistry, it has a different topography. Many of the studies you're going to see on PEEK in the literature do not compare apples to apples. They compare a PEEK surface to a smooth surface titanium or a rough surface. It's just craziness. These are not well-controlled studies, and so I'm going to show you data from a study that is extremely well-controlled. In this case, we have a smooth surface implant, we have a the rough titanium alloy vanadium implant, nanoLOCK, and compared to PEEK. Now, how did we do apples to apples instead of apples to oranges? The PEEK surface and the smooth surface of the titanium alloy were prepared by machining the same way. So we have two smooth surfaces, and then we have the nanoLOCK surface. And you can see, just looking at these, that the roughness values are quite a bit different. And so the data show you that. But really importantly, I want you to focus in. We have better alkaline phosphatase activity just by moving on to titanium. And if we get the right surface titanium, even better alk phos activity, and certainly better osteocalcin. We are getting better osteoblasts. On PEEK, we are not getting osteoblasts. These cells are not differentiating down an osteoblast differentiation pathway. They are producing BMP2 on titanium, and even more on the nanoLOCK, more BMP4 on titanium, and BMP7, which is a less effective version of one of the BMPs, it is being produced by cells on all of these surfaces. But if you really want to get the surface of interest, it's better to have BMP2 and BMP4. More data. Osteopintegrin. To control the rate of osteoclast formation, much higher on the nanoLOCK surface. Active TGF-beta, better if you're on titanium and with latent TGF-beta. That's TGF-beta for the future that will help control osteoclastic resorption, best on the nanoLOCK. Angiogenesis, VEGF, FGF2. You can see that when you move off of PEEK, which is not encouraging cells down an osteoblast differentiation pathway, instead down a fibroblast differentiation pathway. Just moving to titanium is an improvement, but moving to the correct surface of titanium, much, much better. Okay, now this is the award-winning IMAS paper, and Paul Slozar is a part of this, and he may show these slides again, but I just want to drill it home so that you understand where I'm coming from. This is PEEK and smooth titanium prepared exactly the same way by machining, so the surfaces, their physical structures are very, very, very similar, and against nanoLOCK. And again, I want you to look at, now we're looking at the activation of different kinds of mediators, and this slide shows you the inflammatory mediators, and the blue, dark blue, purplish blue is PEEK, smooth titanium is green, and the nanoLOCK is a cool sky blue. And it doesn't take a rocket scientist to look at these data either to see that titanium alone is an improvement, but nanoLOCK is best, that inflammatory mediators are markedly reduced on nanoLOCK. Factors associated with cell death. This is programmed cell death. Upregulated on PEEK, downregulated on titanium, improvement even on the nanoLOCK. Cell factors related to cell death by necrosis, which is like really a bad way to die, upregulated on PEEK, downregulated on titanium, even more downregulated on nanoLOCK. And these are now measuring actual factors, just to tell you that it's not just looking at a general screen. This is like actually measuring these factors in the medium that are produced by these cells. And you can see the inflammatory interleukin 1 beta, lowest on nanoLOCK, interleukin 6, lowest on nanoLOCK, interleukin 8, lowest on nanoLOCK, highest on peak. And at the anti-inflammatory cytokines, which are also necessary, these are also necessary for normal bone healing, interleukin 10 is lowest on peak. So why, and this is my summary slide, why is nanoLOCK so different? It has the macroscale, microscale, and nanoscale topographic features on the surface that resemble very closely normal bone surfaces that are prepared by osteoclasts. When we talk about the cells, we know that these mesenchymal stem cells, these progenitor cells, they're able to attach to this surface, they're able to differentiate into osteoblasts, and they produce factors that tell other cells in the environment what to do by causing them to also become osteoblasts and delaying bone resorption until bone can form on the surface. And what we really want to stress is it's not just the surface, it's not a short-term outcome, that the result of using the correct surface, or a surface that these cells really can interact with in a positive way, we will wind up with really good osseointegration, high quality osseointegration on that surface. We don't need to have a bone ingrowth into pores, because the surface itself will cause the bone to form in that space between the bone bed and the implant in an appropriate, regulated way to get the best possible outcome. So I want to thank you, and again, I want to thank Titan Spine for giving me the opportunity to work on a really fun project. Thanks.
Thanks, Barbara. I'm going to take over. This is Paul Slozar, and my role is to pick up where Barbara has left off, and you'll see obviously the slide on your left a few times more, but it's really one of the most remarkable slides that I think I've seen. And the idea is to help you guys understand that what goes on a cellular level with an osteoblast interacting with a nanoscale surface translates into the picture on the right, where you actually get a good clinical fusion. The way I view the nanoLOCK titanium is that we now have access to a biologically inspired implant. And as Dr. Boyan described, these implants can be sensed by individual cells, and ultimately we're trying to drive osteoblastic differentiation. And what that means on a clinical basis is we're going to get rapid bone formation and osseous integration with the implant. When I first began working with Titan and was exposed to their first generation implant, it dawned on me that the issue of surface technology, at least then, was a complete blind spot to most spine surgeons. And that's in distinct difference to orthopedic total joint surgeons, who are very engaged on the issue of surface technology and the dental industry. But it's not our fault alone. We have been brainwashed by the marketing departments of a lot of the large implant manufacturers to simply think that the implant itself was a carrier or a vessel to bring in the biologic. Otherwise, we wouldn't have been so naive to think that we, being the spine surgeons, are the only people putting plastic in between two bones in the entire orthopedic universe and thinking it will fuse. As you may be aware, but I'll point out to you, there is only one nanotechnology cleared by the FDA in orthopedics. That's all of orthopedics, and that's the Titan Spine implant. And this led to, after presenting the data that I'm presenting in short form, as well as the science that Dr. Boyan presented, to CMS, the first new technology code to be given in 20 years. So the nanoLOCK is a unique device, and that is important as it pertains to the issue of scientific veracity. And as Dr. Boyan described, very meticulous science that has been going on specific to Titan for the last 8 years, but specific to the idea of surface technology and bone integration for 20 years plus. Since the clinical benefits have become obvious to the spine surgeons and they are using more implants, the marketing departments of a number of companies are utilizing science that has nothing to do with the technologies has been primarily published by Titan Spine and our scientific partners, specific to one surface technology, and that's the Titan Spine technology. So simply putting titanium on your implant and quoting our articles, while not illegal, is really opportunistic marketing. It's designed to confuse and confabulate the surgeons who can be vulnerable. They do not necessarily have the time, and they can be taken advantage of, unfortunately, by sales reps. And I think this type of implant, I want you to look on the left, and you tell me if you think somebody putting pock marks on the surface of an implant correlates in any way with the scientific academic research that's going on citing BMP release, which has nothing to do with the implant on the left, has anything to do with a surface of this sophistication, then I think you missed the first part of the presentation. So understand what we're looking at is a very unique and specific interaction that drives osteoblasts, which drives bone formation, and ultimately results in a good clinical result. The first research that I undertook with Titan was on my own patients. I presented this at a couple of meetings. This was back in 2008 to 2010 when I began using the implant. We collected prospective data on 72 patients with 1 to 3 level lumbar fusions, and at the time I was still using infuse primarily because I was having good results, but I was seeing a fair amount of inflammation, subsidence, and some uncontrolled reactions with the product. So I cut my infused dose in half, but I wasn't quite ready to take the needle out of my arm yet until I was sure that the clinical results were acceptable, and they were. So at 24 months, we saw significant improvement in VAS scores, visual analog scores 0 to 10, 10 being severe pain, 0 being none, in both back and leg pain. And Oswestry Disability Index, which is a common tool used by researchers to look at overall function of patients. The treated patients showed significant improvement. And the thing that struck me was that the ODI and VNS scores were significantly improved in the majority of the cases, but really what sort of struck me, and this has led to a comment from surgeons who've begun using Titan spine implants, is that the patients felt better faster. And what we saw in terms of clinical results at 6 months stayed put. We used to tell patients it's going to take 12 to 24 months to achieve a meaningful clinical benefit from your fusion, and we began seeing it at 6 months, which has played out. The other clinically important issue as it pertains to titanium is that it carried with it a lot of old baggage from the cage rage days. Pictures on your screen show some of the original type cages that were shotgun shells, and these ate up a lot of space. They subsided terribly, and it was very difficult to image them. So there was a lot of concern and confusion that you couldn't really scan these patients. One of the purported benefits of PEEK, and I just want to go online, I really never made sense to me to use plastic, so I rarely did. But one of the benefits of PEEK is that you can see how well it doesn't heal on a CT scan, and there's not as much artifact. And understand, if you look at the arrow on your left where you can actually see part of the PEEK, remember, anywhere there is PEEK or plastic, the bone is not integrated. So you have to fuse around PEEK or through it. The implant cannot participate in the fusion. So we undertook a CT scan study utilizing 2 independent radiologists to look at the Titan spine implants and determine if they could really agree on the visibility of the cages and whether or not these fused. We randomly selected patients at 6, 9, and 12 months who underwent CT scans. The 2 independent radiologists were blinded to the clinical results and each other's interpretations, and then we calculated the inter-observer agreement. We had 33 patients, 56 spinal fusion segments, and what we found as it pertains to relevant issues, subsidence and artifact, we had essentially no subsidence to minimal in the majority of cases, which is consistent with the rapid integration of the implants, and, the subsidence does. And then the artifact means, can you see around these implants? And the radiologists said they could quite easily. And these are just a couple of pictures. If you look, this is what we tend to see. I describe this as a spot weld. You see this bone reaction directly with the implant. Very easy to see these on CT scan. Relatively little artifact and scatter. And you can see how good the disc space height is, no subsidence. And when you get to the middle of the implant, you can clearly see bridging bone growing across it with minimal artifact. The most important question the surgeons want to know, do these heal? And we looked at the fusion grades, with 5 being definitely fused and a grade 1 being negative for fusion, definitely not fused. The overwhelming majority of these patients were deemed definitely or probably fused, and there was a high inter-observer agreement between the two radiologists. And again, an example of surface integration. We just don't see this type of surface integration with PEEK and even with cadaver bone. It's very difficult to maintain this level of platform non-subsidence. And again, if you want to look inside the cage and see if there's bone growth, you can with CT scans. So in conclusion, this data showed that fusion criteria can be reliably assessed with a high degree of inter-observer error and minimal artifact, and there was very little subsidence, which is clinically relevant because subsidence is indeed a form of a compression fracture and is painful. So the doctors who believe that partial subsidence is necessary part of healing, those patients will undergo a significant clinical decline during the time of subsidence. The next paper that I want to present was performed by Dr. Girasoli. He and his co-authors looked at transforaminal interbody fusions, and these were all with demineralized cancellous allograft bone, no BMP. They had 82 patients. They used cancellous local bone as well as some augmented allograft bone, and they did the same thing. They had independent radiologists assess the CT scans. As you can see, again, with a TLIF implant, you can see bone behind the cage, you can see osseous integration, and good visibility in disc space height restoration. The conclusions from this study were that the fusion rates at 6 months was 93%, and the 12-month fusion rates 97%. Again, no device-related complications or clinical subsidence. And these fusion rates were consistent with previous studies that utilized infused BMP. So we're getting away from the idea that you need to use a high potency or expensive biologic when the interbody implant is actually engaging with rapid integration. And this is just a pre and post-op x-ray demonstrating disc space height loss and disc space height restoration with end plate subsidence at a minimum. The next data that is currently in processing, but I wanted to share with you, I've redacted portions of it as we have not formally published this yet, but what we did, we looked at a single site, 174 patient TLIF, 2-surgeon site, and in conclusion that we've just crunched the data, we found that there was a clinical outcome benefit in both in leg and back pain reduction that was statistically significant, along with oswestry disability improvements that was detectable at 1 month after implant and sustained at the 3 and 6 month intervals. Again, what we're hearing from surgeons and seeing on a clinical basis, and as the research and clinical data is being digested, we're seeing more rapid improvement, and we believe this has to do with the rapid triggering of the osseous integration, which is occurring with the implant. A portion of the data that I presented to CMS to get the new technology code in June of this year had to do with Optum data. And Optum is a large data clearinghouse that is used by insurance companies, and we asked them to go back and look at our implant versus the rest of the industry. So they came up with 672 patients that were tracked for 24 months, and these were all matched up on all the appropriate demographic variables. And there was a whole bunch of data that came out of this, but the clinically important data that seems to resonate with the surgeons was that, first of all, the patients were able to achieve a clinical result which allowed them to start physical therapy much sooner. On average, 51 days at the Titan spine implant fusion patients compared to 117 days for the competitors. And I understand this isn't necessarily hard objective data, but if you look at the way surgeons practice, the idea of sending somebody to physical therapy is typically a shared decision between the patient and the surgeon. So the patient has to feel good enough to go to physical therapy and want to go, and the doctor has to feel comfortable enough that the bone is fusing rapidly in order to put them there. So the idea that they took everybody else in the industry and compared it to the Titan spine implants, I think that's meaningful data. There was also a beneficial effect as it pertains to downstream costs. The Titan spine patients were discharged sooner from the hospital. They had a lower cost of episode of care. Their 2-year costs were lower, and they had an earlier physical therapy utilization, as I previously described. So the next thing I want to talk about, just very briefly, is the 2 ways these types of implants that are currently available on the market are primarily produced. Subtractive processing, which is the way the Titan Spine nanoLOCK is produced, is that you have a block of titanium that is treated with an acid etching and specific proprietary commercial preparation. It leaves behind the original material, and you can get down to the micron and nanoscale surface by doing this. The original material is still bonded. It does not weaken the original material. Additive processing, which are essentially coatings, is where you either spray titanium on titanium or you spray titanium onto a plastic surface. Clearly, that's going to be a weaker bond than a subtractive process, and at this point in time, they are unable to achieve an actual nanoscale surface. And as Dr. Boyan pointed out, if you want to talk to a cell, if you want to integrate with that lock and key phenomenon, which triggers the osteoblastic differentiation, you need nanoscale. Simply roughened titanium that is macro rough will not do the trick. One of the implants that is available on the market across the board on a commodity basis are titanium sprayed PEEK implants. They're essentially all the same at the end of the day. And there's a considerable amount of concern in the surgeon community about delamination risk and particulate debris. The other thing that's purported by the marketing departments at a lot of these companies is the benefit that it has a modulus of elasticity more closely resembling bone. And obviously the partial radiolucency is been noted, but we can see around these with a CT scan as I've described. But I want to just pause for a minute to educate those who care to be educated about the issue of modulus of elasticity. And again, this is a marketing myth that's been purported. The titanium is too stiff for the interbody space and will subside. Well, clearly we're seeing that that's not the case with the images I've showed you, and that the idea that PEEK is closer to the modulus of elasticity to bone and will not subside. And that's not the case. On a scientific basis, the modulus of elasticity is actually a property of the material. It has nothing to do with the stiffness. So objects can have the same elastic modulus but different strength and stiffness. And the most easy example to understand is aluminum foil. Aluminum has a modulus of elasticity. The material has its own modulus. The modulus is unique to each material. So you can take aluminum foil, you can take aluminum and make it into a soda can, and you can take aluminum and make it into an airplane fuselage. Now you tell me which one is stiff and which one is not. Similarly, paper. You can do different things to a piece of paper and change its relative stiffness, but the modulus of elasticity remains the same. So the idea of what you do with a PEEK implant in terms of preserving its modulus of elasticity is, number one, irrelevant to a cell. Cellular signaling has nothing to do with modulus, and the idea that PEEK won't subside is a myth. The other very concerning issue that I'm starting to get extraordinarily worried about is this issue of delamination. I'd say on average, in a typical month, I get 2 to 3 slides emailed to me about delamination. The pictures I'm showing you are from a surgeon colleague of mine who simply repositioned his TLIF implant. He put it in, he didn't like the position, he pulled it back out to reposition it, and this is what came back out. This is unacceptable. We took a look at this under the supervision of Dr. Wilke in Germany. He looked at 6 titanium-coated PEEK cages and 6 surface-etched titanium cages similar to the preparation of a Titan spine implant, and they looked at the biomechanical forces that a normal surgeon would use to impact a cage into the disc space, and they evaluated it for wear debris or delamination. And what they found, as you can see in these slides, that the additive manufacturing where you spray titanium onto a PEEK cage had significant problems with delamination and wear debris. And these are just some pictures of the polystyrene block that was used. So the titanium was scratching off it and being left behind. And this is the implant where the skid mark shows the titanium being worn off. So the Titan spine cages, which are a subtractive process as previously described, showed no signs of debris or surface damage, 0. In contrast, the titanium-coated PEEK cages had 26% of the coated implant teeth were abraded. And the really significant problem, it's not the particles that you and I can see necessarily visibly. Those can be picked up if you can find them all. But it's the ones that are on the 5 to 10 micron scale which were being worn off and left behind. That size of a particle is unfortunately the perfect size for a chronic inflammatory reaction. The body will try to destroy that as a foreign body, and it's never going to be successful. The body cannot kill a piece of titanium. So we'll typically undergo a chronic inflammation-mediated osteolysis reaction, and I'm concerned that in the future we're going to see much more of that with these late-stage implants. Just to wrap up, I'm just going to show you a clinical example of a patient that came to see me. This is a patient who had a peak expandable cage placed at a single level by TLIF, and there is some interest in expandable cages. I'm going to save that for a different discussion, but be that as it may, if you're going to put in an expandable cage, you probably shouldn't put it right in the center of the disc space, which is the most vulnerable to subsidence, and expand it. You can see here basically the footprint where the cage basically just subsided up into the bone, and essentially there's no fusion here. It's all cage. So predictably, this patient didn't do well. I went in from the front, opened up the disc. I simply slid an instrument under the device on the top and bottom, and it popped out very easily like a watermelon seed. There's just no fusion here. This is just essentially a spacer. And then I replaced this with a Titan interbody fusion implant, and the patient healed in 3 to 6 months. In conclusion, the nanoLOCK is a unique, proprietary, sophisticated roughened surface, 10 to the -9th, rough to the point that you can't feel it. You need an electron microscope. So if you can feel it with your finger, that doesn't mean it's rough to a cell. The nanoscale technology allows these implants to actually be sensed by the individual cells which drive osteoblastic differentiation, which leads to rapid bone formation and osseous integration. And what that translates into for the typical surgeon or clinician is rapid osseous integration, early return to function, and lower downstream medical costs. Thank you for your attention.
Thank you, Dr. Slosar and Dr. Boyan, for that fantastic presentation. We're now going to go into today's Q&A portion. I want to remind everyone to please submit any questions you have by typing them into the control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get to as many questions as possible. So, Dr. Boyan, I'm going to steer this question towards you. One audience member says, I understand that a lot of your initial research on medical implants began in the dental industry. What differences, if any, are there between surface technology used on dental implants versus those used for interbody fusion?
In the simplest version, I think that the dental implant experience gave us a lot of information about what are the general properties that cells that we want to become osteoblasts will generate. What kinds of environments do they prefer, and what are the possibilities of things they might do while they're in those environments. But the dental implant world began using commercially pure titanium, which is a similar surface but not identical surface to the titanium, aluminum, vanadium alloy. There are some subtle differences in the oxide surface, in the chemistry of the overall implant surface. So while it's been very helpful to understand what the dental implant world has told us, we still have to go back and rethink it for the orthopedic world. And there are different forces that these implants are exposed to, and slightly different expectations of how we need those implants to operate over time. So I think it's been really interesting to participate in both processes, but the way that the dental implant industry has gone forward has been a little bit different than what we need to do in spine. And so we haven't replicated the two. We haven't taken a dental implant surface and replicated it for spine. We've created one specifically oriented towards spine.
Thank you, Dr. Boyan, for clarifying that point. There's another question, if you could answer, please. One attendee is wondering, it seems that the interbody fusion market is trending significantly towards surface-enhanced interbody implants, and a lot of companies are jumping on the bandwagon. How much of a difference is there between these various technologies and the responses they elicit?
Well, I tried to show how just making small changes in a surface can produce a big change in the outcome. And if you'll let me do this and go back to the anodized surface versus the etched surface in the dental implant world, that small change in the shape at the nanoscale, mesoscale, actually elicited quite a big difference in the clinical outcome. At the cellular level, in the Titan spine materials that they provided to me, those kinds of differences I showed you, they're very small, and yet the cells actually do recognize them. So we have to decide what is important to us philosophically and what's really important to a cell in real life. And the cells are operating in a different length, hierarchical length scale than we are. So do I think they matter? Yes, I think they do. Do they matter in how would that be seen? I think that Dr. Slozar has shown some good indication that it does matter clinically in the end. I don't think that the way that the field is going, trying to take advantage of our observations with implants that are not really designed to be done that way, is going to get them the outcome that they're after. And part of the problem is this. With a plastic, it's very, very, very difficult to replicate a metal surface on plastic, partly because plastics don't hold that surface over time. And believe me, we have tried in our laboratory. We have now tried many different ways of getting to that problem of figuring out how to make a plastic have the same kind of surface that we can get on a titanium alloy. And we have not been able to successfully do it and get the outcome that we get with titanium. We can replicate one or two of the properties. We cannot get the full scale difference. So simply taking PEEK and roughening it and then overlaying that with a sputter-coated titanium surface will get you a titanium sputter-coated PEEK surface, but it isn't going to be the same as having the titanium alloy with the surface design from the outset. I just don't think that you can't cut corners on this one. You can't try to make something that wasn't good better by coating it with titanium.
Thank you, Dr. Boyan, for clarifying on that as well. And there's one more question here, Dr. Boyan. There seems to be somewhat of a debate and even confusion about the concepts of bony on-grown versus ingrown to the surface porosity. Can you kind of elaborate on the differences between the two?
I'm going to do it as simply as I know how. If you look at implants that are used in total joint replacement, what is often done is that beads are sintered onto the surface to provide porosity that will allow a mechanical interlock to form, because bone will grow into those pores and create a mechanical interlock. And that is one way of achieving achieving an integration between an implant and a bone bed, and it certainly does work there. If you do that with PEEK, if you create, in essence, beads on the surface by using a porosity, using a dissolvable component, and then extruding PEEK around that dissolvable component, removing the component, and having then cells grow into those porosities, you will in fact get a mechanical interlock. But you will still have the PEEK surface to deal with. So at the actual interface between bone and the implant, you will still get that fibrous connective tissue interface. You will have an improvement because there will be a mechanical interlock, but it will not be the same as what you get with the Titan spine approach, where in this case you don't need to have the cells grow into a porosity. They grow up so close to the implant that they form a real osseointegration. The interface between the bone bed and the implant is as close to perfect as it is possible to get between two materials. And so in essence, the implant is locked into place by the bone that's right next to it.
Thank you, Dr. Boyan. And that's all the time we have for today. I want to give a huge thanks to both Dr. Boyan and Dr. Slozer for their excellent presentation and to our audience members for participating. I want everyone to please enjoy the rest of their day. We look forward to having you join us for future webinars. Thank you.